I would invite Dr. Aditi Pujari, who's a consultant at Sunayan Oculoplasty Center from Aster Aadhar Hospital, Kolhapur. And she's going to be taking us on a different part on trauma, periocular fracture, my approach. So on to you, Aditi.
Thank you so much, Chitra madam and Dr. Vidya ma'am for the opportunity. Yeah, so I'll be basically taking through the periocular fractures, covering just the basics, because I'm sure next speakers are going to go ahead with more complex fractures and all the patient-specific implants and everything. So just the clinical things when we actually go ahead with treatment and when we just leave alone the patient, these are the main things which I will go ahead. So before starting, we all know the bony anatomy of the orbit. Here, while talking about the fractures, we mainly need to know about the medial wall as well as the floor of the floor of the orbit, because these are the two common places where the blowout fracture is very common. Obviously, with a more forceful trauma like RTA or any forceful injury, even the zygomatic bone, the lateral wall, as well as roof is also involved in many of the cases, especially where the trauma is very strong. So what do we evaluate in a patient who where we are suspecting fracture of or we want to rule out fracture, what we actually see? So before starting any ocular evaluation, first thing, because I work in a multi-specialty hospital, many a times fresh polytrauma cases come. So first thing which we need to see is the GC of the patient. So the priority list wise, it will go about the GC of the patient, followed by the eye, followed by the vision. So that is a routine thing which we evaluate. So once we are confirmed that GC is fine, and if the patient is a cold case who has come to OPD, so we ask about the history, basic ocular examination, ocular movements, because we want to know if there is any restriction of the ocular movement, which can be due to either a nerve injury or can be due to the muscle injury or entrapment or muscle prolapse. Presence of any inophthalmos or sometimes even proptosis can be there in few cases initially when there is a hematoma or a lot of edema is there post-trauma. Then another thing which we need to see is infraorbital hyposthesia or anesthesia, because many a times the infraorbital nerve is going to get damaged. So we need to check that preoperatively. Sometimes while putting the implant or handling the floor, that can also get damaged. So we need to actually document if it is missing since the beginning or it has got affected post surgery. Then comes the malar flattening, which is generally because of the zygoma fracture, which is the loss of the malar prominence of the face, and obviously trismus or difficulty in chewing or the bite is not correct, which will involve mainly the lower part of the face, including mandible or the condylar fractures. So now when we see any patient, such patient is coming to OPD, who we want to rule out or rule in fracture, what we need to see is most common features are superior sulcus deformity, inophthalmos. Many a times even with a gross inophthalmos, the eye looks slightly bigger when compared to the other eye. If there is a zygoma fracture, even the lateral canthal position is also disturbed if there is no other wound or any improperly sutured laceration is there. So because the soft tissue or the bony anatomy changes, so that is going to slightly change the lateral canthal position also. Another thing, again, with the muscle entrapment or prolapse, there is going to be some limitation of the movement in up gaze or maybe medial or lateral, depending on the which muscle is actually involved, and obviously inophthalmos when the initial edema or hematoma, whatever is there, is settled. So when we actually order a CT scan, it is very important to order a proper CT scan where we want to order a CT orbit, which should include bony as well as soft tissue windows in axial, coronal, as well as sagittal cuts also wherever possible. So here we need to see what kind of fracture is there, whether it is involving the strut, what walls are there, is there any muscle entrapment or prolapse. So there is a difference between entrapment and prolapse. I'll be showing few cases of entrapment as well as prolapse. So I'll explain that during that. So these kind of patients who are like now cold cases, or sometimes in children where we call it as white-eyed blowout fractures, they just have the entrapment of the muscle. So most of these cases will have very minimal enophthalmos, but gross restriction of the movement. So these kind of restriction of the movement where the eye is absolutely not moving. So those kind of patients are most probably going to have entrapment and not prolapse. So here what you can see is the size of the fracture is not very big, but the tissue is prolapsed and the muscle is actually entrapped. So the prolapse is a bigger fracture. I'll just go back and show it here. So it's a bigger fracture. All the tissue along with the inferior rectus is prolapsed. So this patient is going to have some amount of elevation, but not a complete free elevation. So here we need to see if it is an entrapment or prolapse of the muscle. Again, now these kind of patients where you can actually observe the right malar prominence, which is flattened when compared to the normal left side, these patients most probably have a zygoma fracture. But if there is only zygoma fracture without any floor or gross medial wall fracture, the patient is not going to have any gross limitation of the movement or any gross enophthalmos. So malar flattening might be the only sign which is there in these patients because of the zygoma fracture. Again, while ordering the CT scan, it is very important to order for soft tissue as well as bone window. So now, in this case, where this is a coronal cut of the soft tissue window. So here, because of the window width and window level differences, you cannot actually make out if there is any medial wall fracture. But if the same patient we see on the bone window, you can actually properly see the fracture which is there, which is missed because of the soft tissue window. However, you can actually see the rounding of the muscle and displacement of the muscle, but the bony fracture may not be seen clearly on the soft tissue window. So you may miss few small fractures in case if you're just reviewing the soft tissue window and not bony window. But thankfully, most of these patients hardly have any restriction of the movement or enophthalmos, because the fracture is such small that there is not much of prolapse or entrapment of the muscle or any other tissue like orbital fat. So these patients where you are actually able to see clinically gross enophthalmos hypoglobus, but when you are actually seeing the CT, the fracture looks pretty not very big or greatly displaced. So it is very important to actually see the other eye also. Now, when you actually see the other eye, we actually get to know that the orbit has absolutely expanded. So the fracture fragments are uniformly displaced. So it doesn't show a proper teardrop sign or anything, but there is a gross increase in the orbital volume, which is causing gross enophthalmos. So now coming to the treatment, do we treat all the cases? So now this patient was referred by ophthalmologist because this patient had trauma, got the CT scan done, and CT scan showed floor fracture. But even after resolution of the edema, patient never had any restriction or limitation of the movement, no diplopia, not much of enophthalmos also. So these kind of patients we can safely avoid any treatment because there is no symptom. What are we going to tell the patient? What symptom are we treating? We have done the fracture repair, but what have we cured? So these kind of patients, surely we can just observe if there is not much of cosmetic problem or functional problem like diplopia. Similar is the case here, even the fracture is bigger.
Doctor, 1 minute more.
Yeah, the muscle has prolapsed, but there is no restriction of the movement or gross enophthalmos can be surely observed. This patient had enophthalmos with the prolapse of the muscle, but patient was not much bothered about the enophthalmos. So unless it is a cosmetically concerning enophthalmos for the patient, we can just still observe if there is no functional deficit or any diplopia. So this patient actually came with sudden chemosis. He had history of some coconut falling on his head some 2-3 days back. And suddenly this developed the day when he presented. So on CT scan, actually, there was a small, again, medial wall fracture with multiple air pockets. So on asking the history, he had blown his nose, and that had made the air enter the orbital cavity, which caused the chemosis. So there was a medial wall fracture. It was not very much bothering him because there was no diplopia, nothing else, but suddenly he blew the nose, and then this entered and the whole problem started. So just I had instilled paracaine drops just to make sure that the eye is closing properly, and then just punctured those few bigger air blips, and the patient was doing well. No diplopia, no inophthalmos, again no functional deficit. So we just observed the case in these kind of patients. So it is very important to tell the patient in cases of medial wall fracture to avoid blowing of the nose, which is going to cause sudden proptosis or sudden chemosis because of air entry through the sinuses. So my criteria for surgical intervention: muscle entrapment or oculocardiac reflex. Diplopia mainly in primary and down gaze, because those are the main functional gazes. Significant inophthalmos, which is generally more than 2 millimeters, any degree of inophthalmos which is bothering the patient cosmetically. Even if it is 3 millimeters, patient is not bothered, I generally go ahead with observation. My preferred approach is transconjunctival, which can be transcaruncular or inferior fornacial, depending on which fracture I'm dealing with. But if there is any pre-existing scar or wound, we can actually go through it. Orbital rim approach is another one, which many of the maxillofacial surgeons prefer. So again, this patient bothered about inophthalmos, not much of diplopia. We went ahead with fracture repair. This was a pure blowout fracture, no fracture otherwise. Gives a very good inophthalmos correction with the implant insertion and retrieving all the orbital contents again into the orbit. So this patient had actually entrapment. So here you can actually see there is not much of a bigger fracture, but the muscle is entrapped. So these kind of cases, we actually sometimes need to widen the fracture margins and avoid pulling the muscle, otherwise it will get broken, and then just put some barrier so that the contents do not prolapse into the maxillary sinus, and it surely gives a very good outcome, because these patients are really bothered because of the diplopia with because there is a gross restriction of the upgaze. Obviously, these kind of bigger fractures need improvement, but sometimes we need to take care of some residual soft tissue injury like symblepharon, improperly sutured eyelid, which can be addressed at the same time when we are addressing the fracture in cold cases. So this patient, I'll just finish up with one or two cases. So this patient actually had a glass injury. She was wearing the glasses which broke with the RTA. So the rim, glass rim actually damaged it. So we did the lid tear repair, but obviously she had restriction of the movement in upgaze. So I generally prefer to wait for 2 weeks in these kind of cases where I need to know the degree of inophthalmos. She was also bothered about the lateral canthal angle, which was slightly displaced. So with this fracture repair, we went ahead with the lateral canthal reconstruction also. So the canthal angle was made symmetrical, fracture was addressed, and then she was very happy with the correction because diplopia was resolved and inophthalmos was also resolved. So these kind of patients, earlier, they'll surely have proptosis kind of features because of the hematoma in the eyelid or maybe orbital, but when it resolves, you can actually see the superior sulcus deformity, and then you can decide which kind of implant you want to use, what kind of volume augmentation is needed. So I'll just finish with this interesting case, which was referred as a for lid tear suturing. Patient had some injury because of some firecracker, and then to our surprise, there was a large foreign body which was seen along with the small medial wall fracture. And when we actually opened it, we were just trying to pull it on, and it came out to be something bigger because he had used some kind of firecracker, this thing inside this to increase the blow of that fracture. So it is very important, in case we miss this and just suture the lid on this, we will miss the foreign body. So it is very important to suspect orbital foreign body even if the entry wound is absent or very small. So to just summarize, proper evaluation is absolutely important. Appropriate radiological and clinical correlation is important. Decide if the case actually needs surgical intervention. rule out foreign bodies, and counsel for realistic expectations, because not every fracture is going to get a perfect symmetrical appearance with the other eye, or perfect appearance which was there pre-trauma, pre-fracture. So counseling is very important. Thank you so much.
Yeah, Dr. Aditi, that was such a wonderful talk. And Vidya, you take one question and we should move on. We'll be running late otherwise.
Yes, madam. Aditi, that was an excellent presentation. You had highlighted everything, all the whatever we wanted to know, you had highlighted. There are a few things that I want to know. What about the concurrent injuries with which affect the optic nerve? How do you
Vidya,
treat that?
could you direct the questions to our expert panel, keep them involved?
Yeah. Madam, not just to Aditi, all the expert members are please feel free to answer all the doubts or queries that I'm raising, so that we have a good discussion on all the points. So I would like to know about the concurrent injury to the optic nerve. So how do you treat that? That's one point. Sometimes we also find in blow-in fractures, which is again a gray zone. How do you treat that? So that is along with the floor repairs and medial wall fractures, we usually deal with that. What about the blow-in fractures that cause impingement of the muscles, which can cause elevation restriction? So there are few cases where we had this kind of problem. So how do you deal that?
So for the concurrent injuries, like while evaluating, you'll obviously see some RAPD or some decrease in the vision. So in case there is no other injury and you're giving a very good antibiotic cover, I think it is worth giving the steroid trial if there is no direct impingement, and I assume that it is indirect trauma. And most of my cases, unless there is some concurrent maxillofacial surgeon who wants to chip in very early, I would prefer to wait till 14 days. So till that time, the optic nerve and everything will be taken care of, because it needs to be taken care of in the initial period. So yeah, other people also, please.
Dr. Raguraj,
Uh,
anything to add?
Actually, the thing, it spontaneously responds. So if there is a traumatic optic neuropathy, I wouldn't go in early. I would wait till it gets better, because you want the patient also to feel that his vision is improving, and most of them spontaneously improve. And if there's a traumatic optic neuropathy, I usually start them of IVMP, because it serves a dual purpose. Of one is something to give so that the swelling and all comes down, and the patient also feels that his edema is coming down. And as spontaneously also, the vision also gets better in many cases. So if there is a traumatic optic neuropathy at the same time, if the fracture is there, I would wait for at least a week before we intervene. Say I wouldn't go in early, even if there's a big gross fracture is there, I wouldn't go in early when there's a traumatic optic neuropathy. That's one thing I would like to add.
Dr. Vijay, you have anything to add before we go on to our next talk?
I think I'll just take one on the blow-in fractures. So most likely, like if you have an impingement on a particular muscle, it's not causing anything gross deficit, you just leave it the way it is. But if it is actually causing an extraocular muscle restriction, you can just go in and you can trim the bone which is causing, if there is no gross ENOF or any other deficit, only for the release of the extraocular motility restriction which is there. So we've done that for roof fractures and lateral wall fractures, but I have never had a situation with medial wall or floor. And in fact, actually, blowout fractures are more protective mechanism. So, like Dr. Raghu said, I don't think so. If you have a traumatic optic neuropathy, we'd want to like wait a little bit. It's not an emergency. You don't have to go in and rush in like our dear MaxFax colleagues want to just do it. We can wait for some time and then do it.
In the end, you end up taking some of the blame for the vision loss if you go in early.
Exactly.
So better to be safe. And I mean, it's actually psychological only. We're not going to harm anything, but it's always best is to wait for the swelling and everything to reduce before the patient, and then the patient has enough time to decide on the next course of action. Because if you just rush in and telling that we need to, they might think that we're going in to save her vision, save his or her vision. But actually, it's not the case. We're actually only treating the fracture. Just by going in early, we're not actually treating the traumatic optic neuropathy.
Thank you.